Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and biomedical professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in medical and biomedical professionals. NAMS is pleased to announce the launching of a joint NAIIMS NAMS-Navigate CME program from 1st September 2023 for postgraduate students in all the NAIIMS and other eminent institutes of national importance from Andhra Pradesh, Arunachal Pradesh, Assam, Bihar, Chhattisgarh, Goa, Gujarat, Haryana, Himachal Pradesh, Jammu and Kashmir, Jharkhand, Karnataka, Kerala, Madhya Pradesh, Maharashtra, Manipur, Meghalaya, Mizoram, Nagaland, Odisha, Punjab, Rajasthan, Sikkim, Tamil Nadu, Telangana, Tripura, Uttar Pradesh and Uttarakhand of the country. The program is being conducted online on the first Friday of every month from 3 p.m. to 5 p.m. The NAIIMS NAMS CME focuses on the topics which are of common interest for the postgraduates across all specialties. The aim of the National Virtual Postgraduate Medical CME is to help them to be more proficient in their profession. Each session will cover 2 topics. Each topic will be of 1 hour duration, which includes 45 minutes for presentation by speaker, 15 minutes for questions and answers. Thank you for your kind support.
I welcome you all to today's joint AIIMS NAMS Navigate Medical CME program. Now I'd like to invite Professor Umesh Kapil sir, the Secretary of the National Academy of Medical Sciences, to deliver the welcome address.
Namaskar and good afternoon to all the participants, the respected speaker and respected Professor Shiv and Dr. Srinivas. It's a proud privilege to welcome all of you to the NAMS-AIIMS Navigate program, that is a national virtual graduate CME program. Now, NAMS has been given responsibility of undertaking the continuing medical education in the country. And this particular program has been initiated specifically directed towards the postgraduates in the All India Institute of Medical Sciences in the country, as well as all the eminent institutions in different parts of the country. We have received 904 registration till now, and we expect that all the participants would join us. What we have done is that we are trying to take up the issues or the topics which are of common interest, whether it is a postgraduate is of clinical, paraclinical or preclinical subject. He would find these topics very interesting and informative. We expect that there would be a lot of questions to the eminent speaker, which we have Professor Nikhil Tandon with us, an eminent endocrinologist and outstanding researcher. With these few words, I would like to stop here. And again, I welcome all of you to this NAMS Navigate program. Over to you, Dr. Preeti.
Thank you, sir. Now I'd like to invite Professor Shiv sir, the President of National Academy of Medical Sciences, to deliver the address. Sir is a Senior Professor of Hepatology and Director of the ILBS. He is Director of the WHO Collaborative Center on Chronic Liver Diseases and Viral Hepatitis at ILBS. Over to you, sir.
Yes, I am very grateful to Director AIIMS, Dr. Srinivas, for having included NAMS into the AIIMS fold. We have 16 All India Institute of Medical Sciences, each is a symbol of excellence. Their students like you all are amongst the best in the country. I'm very grateful to all the directors of AIIMS who have joined today and have encouraged the students studying in AIIMS to join this program. NAMS is a symbol of excellence for last 63 years. The best of the best medical brains join National Academy. It is your academy. It is a single umbrella, the largest umbrella, the most colorful umbrella in medicine. Let me show you briefly in a minute. Can I have my slides? Yes. So NAMS has several activities. One of them is to foster and utilize the academic excellence. One of the major academic center like AIIMS, and we are trying to promote this across from one AIIMS to the other and maybe to other centers in future. NAMS also recognizes fellows, which we have about 1,000, and members of the academy, which are more than 2,500. We have started having DM-MCH 3 years after their DM-MCH to become associate fellow. I mean, you can write, I am an associate fellow of the National Academy. It's a big honor. So I encourage each one of you. And also, we have recognized NAMS and we have international fellows. Have a feather in your cap by becoming a FAMS or MAMS. The NAMS also has, like just told, a virtual graduated medical CME. It is to navigate the residents. In fact, all of us, I also learned, navigate for better outcome, better learning, better skills. All these videos for last 1 year are all on website. And today we are very privileged to have AIIMS and NAMS CME. The National Academy has 28 task forces, each on an important topic. Next, please. NAMS has emeritus professors. It has an annual conference, which this year is from 6th to 8th of October in Bangalore, and you will have national quiz. And we have master champions like Preeti and others who really help us into this program. NAMS also, if you are a junior or middle level scientist or a postgraduate, you can certainly go into exchange program. We provide support for postgraduates to go to another center. And of course, NAMS has annals as its publication and an e-newsletter. So please join and strengthen your NAMS. It has this website. For today, I'm really lucky that we have Professor Nikhil Tandon and Sir Chetan, who will give you ideas on different aspects, frontline ideas. But please shoot the questions, please record, and please also participate. With this, one more time, my thanks to Professor Srinivas from AIIMS Delhi and all the other directors of AIIMS for joining hands with NAMS and making us reach you all. Thank you once more time.
Thank you very much, sir. And I like to thank Professor Srinivas, sir, the director of AIIMS New Delhi, who has kindly provided us a message for the NAMS CME program. Professor Srinivas, sir, has had an illustrious career with more than 3-decade experience in various positions in the academic, administrative, and research fields. He joined the institute in 1994 and ascended the academic ladder and became professor of pediatric surgery in the year 2011. So, over to you, sir, for the message from Professor Srinivas, sir.
At the outset, I congratulate the team behind the NAMS-AIIMS Navigate CME program. Providing quality of education to our postgraduate students is one of the prime responsibilities of AIIMS. I know that our able faculty is leaving no stone unturned in achieving this mission. However, there always remains a scope for improvement. Through this unique initiative, there is an opportunity for our postgraduate students to learn from the experts in their field. This learning will go beyond the boundaries of department where our postgraduate students are working and will also bring in more flavor in their knowledge and at the same time ensure dissemination of uniform, high-quality content all across the nation. Postgraduate students also form our primary workforce for providing patient care. This indeed is an important component of their training. We are aware that our postgraduate students devote a large component of their time for the patient care services, and thus they have less time for self-study by the end of the day. The timing of this activity is therefore very carefully chosen. The sessions will be held late in the afternoon so that the beneficiaries do not have to make any extra effort for attending them. This by itself exudes the philosophy of a true teacher, a mentor that will handhold the children through the process of their active learning. As the sessions are online, which by its very design is a non-synchronous platform, it may seem that the delivery of the content will be one-sided, but enough measures have been planned and they are in place to make the activity as interactive as possible. The topic of the session will be shared with the students well in advance. This will allow them enough time to explore the subject and be better prepared to absorb the content. This design, therefore, also matches the concept and principles of adult learning. The program not only will help our postgraduate students in being better prepared for their examinations, but also will equip them with sufficient knowledge, understanding, and approach to be a better professional in their field. I wish this program all success. Thank you.
Thank you very much, sir. Now we have the honor and privilege of introducing the eminent speaker of today's session, Professor Nikhil Tandon, sir, who is a professor and head of the Department of Endocrinology at AIIMS, New Delhi. His chief research interest includes diabetes of the young. He chairs the technical coordinating unit of the ICMR Young Diabetes Registry and metabolic bone disease. Sir has more than 550 publications to his credit, and he has a H index of 72. He had also been the former president of the Endocrine Society of India and Indian Society for Bone and Mineral Research. Sir is also a fellow of the National Academy of Medical Sciences, Indian Academy of Sciences, National Academy of Science, and Indian National Science Academy. Sir is also recipient of multiple awards, including the prestigious Dr. B.C. Roy Award and Padma Shri Award. It's a great honor and privilege to have you with us, sir. Over to you, sir, for today's session.
Good afternoon, and it's a pleasure. I just realized that this is perhaps the first such session in a series of sessions which is being planned, and I'm feel particularly privileged to be invited to interact with the community of young physicians and surgeons of our country. The topic which I will be speaking on sounds like a topic not for a physician, but for an information technology professional, which is a clinical decision support software. What I intend to do, however, is give a physician's perspective. I'm not an IT professional. I know as much about software as anybody else who uses a routine software, but I think it's important to understand from the perspective of a medical professional how algorithmic approach to disease management is important. That algorithmic approach in textbooks of yore used to be on the basis of very simple things. They used to have line diagrams that said, if you see a patient with this problem, do this test. If it's positive, do this. If it's negative, go on to the next one. That's an algorithm, right? But now you can convert that instead of simple pen and paper algorithm to much more complex algorithms, which can be supported by software, and they can then be used to assist management. I use the word assist management advisedly because they will always have their limitations. So my primary plan for this afternoon is to give you a sense of an algorithmic approach and share with you our own experience development of clinical decision support software. And we are fortunate that we've taken it from a point of it being a research project to now being introduced into the health system itself. So healthcare technologies are obviously important, as you know, from let's say 50 years ago to today. Technology could be either a medicine, could be a medical device, could be assistive technologies, could be techniques, procedures. And there's a substantial role and evidence that this plays a substantial role in our day-to-day work. from a perspective of non-communicable diseases, and I'm a person who is from the Department of Endocrinology, and therefore the entire talk will use NCDs and more so diabetes as the example to illustrate what I'm trying to communicate. The important thing for chronic non-communicable diseases is the understanding that it's not a single encounter management plan. So if you have an episode of dengue or malaria or typhoid, you go to a doctor with symptoms, the doctor treats you, and invariably there's a finite course of medicine, which in a large proportion of people cures them of the disease. In NCDs, and here could be diabetes, could be hypertension, these are lifelong diseases. And therefore, it is important to understand the concept of continuum of care, and therefore any algorithmic approach has to address each part of the continuum of care. From a general population perspective or from an opportunistic screening perspective, you first screen a person, diagnose the person, identify what the treatment should be, follow up that person, look at the need for referral. There may be acute complications along the way, and then, if required, rehabilitation. So it's a very long circular process, and we have to understand that the approach towards a patient with chronic disease is very different from an approach to a patient with an acute finite illness. If you look at diabetes, the World Health Organization has for the first time actually understood and supported the creation of global targets, but these global targets recognize the importance of the continuum of care, right? So the 5 targets which we are as a member country supposed to achieve are that 80% of people living with diabetes actually have been diagnosed. There is an old-fashioned rule of halves which says that about 50% of people who have a chronic asymptomatic disease will not even know that they have a disease. 50% of those who have a disease or who are diagnosed with a disease actually are being treated, and 50% of those who are being treated are being controlled. So in reality, only 1 out of every 8 people with an asymptomatic chronic non-communicable disease are being managed optimally. So one of the things which was planned was 80% of people living with diabetes should be diagnosed, 80% should have a good control of their glucose, 80% should have control of their blood pressure, 60% of those who are above the age of 40 years should be on statin therapy for lipid control. So again, importantly, that when you develop algorithms for management of diabetes, it is not or cannot be a glucocentric algorithm. Your clinical decision support should be for all these factors. Just to give you a sense of where we are in India with the continuum of care. So this is data from the National Family Health Survey. We did an analysis district by district of this, and we recently published that in JAMA. And you can see that we are doing better than the 50% rule, but we are not doing as well as the 80% target. So about 75% of people from the NFHS who had diabetes knew that they had diabetes. About 60% of those really were being treated, and about 2/3 of those were under control. But these data are much worse in rural India compared to urban India, clearly indicating that we need to do something more to ensure that we have a better control of people in our. So what really is a clinical decision support system? So these are computer-based programs that obviously are plugged into an electronic health record. So you need an electronic case record form or electronic health record. And on the basis of back-end analysis, they provide prompts and reminders to assist healthcare providers in implementing evidence-based clinical guidelines. Now, this is very important that first you have a platform. The platform is a source of information. So for example, you have a platform which is capturing information about a person with diabetes. What is their age? What is their current blood glucose? What are the medicines they're on? What are their comorbidities? What is the current advisory from professional associations based on evidence as to how their condition should be treated? All of that is then provided as a management prompt to the treating physician Obviously, the physician is the one who will prescribe, and take responsibility for the prescription, but it really helps focus the attention of that physician on the critical points which need addressing and appropriate dose changes. So really, what are the key functions of CDSS in the care of a person with non-communicable disease? It provides reminders to screen if you're going to a general clinic. It flags cases. It provides information on treatment protocols. It prompts questions on medication adherence, and it provides recommendations for health behavior change. And it may also assist in providing triggers for referring patients to an appropriate specialist of care, either in an hierarchical system into a higher level facility, or within that system to colleagues who are handling comorbidities. So if you have a person with diabetes and you're finding that they have proteinuria or the creatinine is getting elevated, they will trigger, you need to send this person to a nephrologist. Now you'll say, what's the big deal with this? We all know that. The issue is, if you're seeing so many patients at one point in time, your objective ability to do many of these things gets interfered in because of the sheer bulk of patients that you see. Now, fine, it sounds very fancy, but does a CDSS really improve outcomes? Interestingly, this has been recognized by the Centers for Disease Control as a best practice intervention for the healthcare system. And there are now significant evidence base which demonstrates the effectiveness of the CDSS. I'm going to share with you in the next 3 slides examples for creation of algorithms, but these are simple paper and pencil algorithms, and these are then converted by interacting with colleagues from the domain of information technology into what we call as rule-based algorithms. This is not artificial intelligence at the moment that I'm talking about. These are rule-based or scenario-based algorithms which will address specific scenarios and give decision prompts. But to start with, and why I'm showing you this is that this is useful for you even if you're not using an electronic health record, even if you're not using a software. If you're sitting with a paper and pencil in the outpatient clinic, these grids, 3x3, 3x4 grids, give you a very clear idea as to what you should do. So for example, this is a decision support table which we made maybe 10 or 12 years ago. So it may not be immediately relevant, but this serves as a good example for controlling glucose in a person with diabetes. On the top of the columns, you can see that we've categorized fasting glucose into 3 broad categories: less than 110, 110 to 130, more than 130 milligram per deciliter. You can decide what you want. On the left-hand side, you'll see we've created 3 categories of HbA1c, a hemoglobin A1c of 7 or less, between 7 and 8, and then more than 8. And therefore, we are generating 9 boxes, right? So if you see the top left box, you say that if somebody has an A1C of less than 7, their fasting glucose is less than 110, they've got good control, and therefore my prompt would be, or the algorithm will prompt the doctor to say, things are fine, don't need to do anything. If you now go down, let's say the fasting is all right, but the HbA1c is between 7 and 8, it's possibly for control. You may want to recheck an A1c. You may want to do a postprandial glucose. And if they are also supportive, you will then look at options. Now, this goes on over the place, and I will come to you in much more detail about this. But again, for example, if you go to the last row, extreme bottom right-hand box, fasting glucose of more than 130, HbA1c of more than 8, very poor control, you need to increase treatment by more. And here I've drawn asterisks. So 1 asterisk, you increase it by 1 increment, and I'll come to you about the concept of an increment. And when there are 2 asterisks, it means you can increase it by 2 doses. Now here is just right. So when we are saying, we actually also developed a concept when we were making these algorithms of creating a 1 unit of each medicine. So we said 500 milligrams of metformin will be considered to be a 1 unit. It's a 25% of the maximum dose of a sulfonylurea will be considered to be 1 unit. 15 milligrams of pioglitazone will be considered to be 1 unit. And therefore, wherever it says add 1 asterisk, so increase treatment, and it says shows only a single asterisk, you can either increase metformin by 500, add a sulfonylurea, or increase the increment by 25%, or add pioglitazone. So this is giving you generic advice. Based on this, we developed scenarios. So if the person is already on, let's say, 1 gram of metformin, is yet not on any other agent, you may either increase metformin from 1 gram to 1.5 grams, or add a sulfonylurea. But that's the sort of multiple scenarios which we then create at the back end. The physician really doesn't have to do anything. These data are already being entered in the electronic case record form. The decision support engine takes it from that, does the calculations, and brings up an advisory. The doctor can accept it, need not accept it, but they're getting a management prompt. And as I said, we are saying that it is significantly poor control and we are recommending a greater increase. You can have 2 incremental increase, so 1 gram of metformin, 50% increase in sulfonylurea dose, etc., etc., etc. The same can be done for blood pressure. You use systolic pressure on one side, so less than 130, 130 to 140, 140 to 160, more than 160. And on the column side, you're seeing 3 versions, less than 80 diastolic, 80 to 90, and more than 90. And again, it's giving you multiple scenarios or multiple cells. If it's less than 130, 80, it means things are well controlled. You don't need to do anything else. You can continue with the existing regimen. If, for example, it is somewhere between 140 and 160 systolic, between 80 and 90 diastolic, it means the control is not good, increase it. Now, these are instinctive. All that we've done is we've objectivized it. It'll gives us these different, so this is a 4x3 grid, so it's giving you 12 broad scenarios. Then the individual scenarios are created under these, so that if it says you're on 5 milligrams of amlodipine and 40 milligrams of telmisartan, and the control is not optimal, you will be told you can either increase amlodipine by 5, you can add telmisartan to another 40, you can add a third agent. So all of this is done at breakneck speed at the back end. Now this is the real background which you and I as physicians, software engineers will convert whatever we tell them. But this is where your, the way you think, the clarity of your thought, your ability to put together a plan will come into play. Because whatever you write out here in this grid will then get converted into software. So this takes a long time, and what we did when we were developing these algorithms, we would run them in outpatient scenario. So the patient would be seen by a non-physician who would take this information, use the algorithms to come up with a management prompt, and then we'll see what the doctor actually did to see whether the algorithms were performing well or they were not performing. Similarly, for lipid management, we were very, again, for an LDL cholesterol, which was the single significant lipid parameter which we were concerned about, we said if it's less than 70, you do this. If it's between 70 and 100, do this. If it's more than 100, do that. The numbers are not important. The numbers are maybe because in 10 years ago, you may have had different targets. Today, you have different targets. But the clarity of your thought in creating these paper algorithms is important. These then get converted into software. So now let me take you through what we actually did. Now, we've actually been involved in this work for a long period of time. And over the last about a dozen years, we've done work in the project mode, so like a research project in primary, secondary, and tertiary care. Then we've converted that experience into a health system performance. So this work which we've done has been now taken up or was taken up by 2 states in Mizoram and Tripura that all their non-communicable disease management in secondary care facilities for about a 3 or 5 year period was being run using these algorithms. And more recently, we are doing this in one district in Punjab, where instead of looking at it separately in primary care, secondary care, and tertiary care, where the algorithms may differ. You may have different diagnostic facilities available, you may have different drugs available, and you may also have doctors of different degrees of skills available. And therefore, the same algorithm may not function equally well in all the levels of care, primary, secondary, and tertiary. So in Punjab, what we've done is we've created a cafeteria choice of algorithms, but they are operational concurrently across all levels of care. And that is also now being incorporated into the health system. So this is just to give you an example of what a management plan will look like, right? So as you can see from the slide, you have an HbA1c of let's say 7.5, and there have been 2 or 3 HbA1c values over a period of time. And the prompt which comes is the patient is not well controlled. This person was on insulin, as was available as information available from the electronic health record. The prompt was review their self-monitoring of blood glucose to their home log and titrate insulin accordingly. Did the doctor agree? The doctor actually did not agree to this advice because the patient actually told them, I was traveling, I did not take my insulin for 2 weeks, and therefore my record is showing poor control. So again, I wanted to highlight the fact that algorithms can work only as well as the information that is provided to develop algorithms. And for glucose control, sometimes it's very difficult to generate all the scenarios. It's like in the winter months, somebody has poor control, want to up titrate, and the patient will say that, it's been so cold where I stay that for the last 6 weeks, I have not been going for my walk. Please allow me to, now that the weather is better, I will go back for my walk, and I'm sure my sugars will settle down. So again, these are multiple scenarios which may or may not be possible to capture in all algorithms, but you can at least prompt the doctor to say, this is something which is not going well. This is what we suggest. If you accept it, it's fine. If not, there should be a good reason for not accepting it. The prompt for blood pressure says that the blood pressure was 110/82. So you could continue with the existing program. The LDL cholesterol was clearly elevated. Here again, the doctor for some reason decided not to increment it. If I was in the doctor's position, I would have, because the LDL is really, really high, and would have benefited from an increase in the dose of the statin. So we did this study in tertiary care, about 1,100 patients across 10 sites in India. We took people with diabetes who were poorly controlled and not meeting their A1C, blood pressure, and lipid targets, and randomized them to 2 arms. Those in whom treatment was being assisted by the clinical decision support software, and those in which it was business as usual. Remember, this was tertiary care. We had sort of well-trained, skilled endocrinologists. Despite that, we found that patients who were randomized to the intervention arm, where the CSS was assisting, had a significant improvement in multiple risk factor control. So even when it's a fully trained person for a specialty, objective guidance using evidence-based guidelines in a clinical decision support software brought about a benefit in management, control of glucose, control of cholesterol, and control of blood pressure. And this really brings the point out very clearly that if you see, and let's just say we concentrate on the LDL target, for example, the extreme right-hand graph. So if you look at people in which case the doctors refuse to accept any of the advisories of the clinical decision support software, and you go to the extreme right bar, which is doctors, when the doctors accepted the DSS prompts, you'll see there is a massive difference in LDL. So clearly the fact that it was a CDSS which was performing well, it was giving appropriate advice, and if you followed that advice, very, very clearly, you are meeting targets much better. The same is seen with systolic pressure, and the same is seen, but not as dramatically, with HbA1c for the reasons that I mentioned, because management of glucose is more complex than management of cholesterol. And I'm happy to report that, you can say, fine, it works, but it's too much work. What will the physicians be happy to do this? We actually conducted a qualitative study at the end of this, and we were delighted to see that the physicians were more than happy to accept use of the CDSS, and they had multiple reasons for doing so. That was tertiary care. This is another example from Himachal, in which we did this at all secondary care institutions in Solan district. And once again, without going into much by way of detail, you can see that this was a pre and post study. Everybody was exposed to CDSS, and you can see a huge reduction in systolic pressure and huge reduction in fasting glucose. So it works. I don't think we need to actually go in much further. Based on this, we then went ahead, and as I mentioned, we're working in one district in Punjab. And based on that, we've now decided to work across all the healthcare institutions in that one district in one block. So all sub-centers, all primary healthcare centers, all CHCs, and the district hospital. And we have a large team and a large advisory board, both national and international, which has helped us to develop this, right? So the evidence-based intervention, which we did, was an electronic case record form. You may be familiar with the fact that the government of India, in their national program for non-communicable diseases, has created an electronic health system, which they use or they recommend to be used in secondary care areas, especially in what are called the NCD clinics. We plugged in our clinical decision software into that government electronic case record. So it's an existing case record form of the government facilities. We plugged in, using an application programming interface or an API, the decision support, which was not only for assisting management, but also to decide, is this patient appropriately being managed at this level? Does this person need more skilled advice? Should we refer? If we refer, how can we facilitate the referral? And how can we coordinate and provide linkages between the primary health center and, let's say, the community health center or the district hospital? We also combined it with healthcare training and changed the workflow in the facilities so that instead of the patient directly going to the doctor, we routed the patient to go through a non-physician healthcare provider, usually a nurse. The nurse would do all the work required by the electronic health record and the clinical decision support software. It was basically data entry, blood pressure measurements, and finger prick glucose, and then it was taken care of by the doctor ahead, right? So we realized immediately that it's not appropriate to expect that all the information necessary for management of diabetes will be available at all levels. So it's very unlikely that you will be able to get an HbA1c at primary and secondary care facilities. So there's no point putting an algorithm there to generate a decision support which mandatorily requires an HbA1c. So we decided we will do whatever, we'll make multiple algorithms, and based on what is available in the electronic health record, one or the other algorithm will get operational. So we said, most people may come with a fasting glucose, so we made a glucose-based algorithm. If you're not even coming with a fasting glucose, there are glucometers available. You can do a random blood glucose. If the patient is better equipped, we said, okay, fine, we can have both fasting and PP. We can have an HbA1c and fasting. We can have an HbA1c with fasting and PP. But, we need some glucose value. And as I said, even if there's nothing available, you can do an immediate point of care random glucose and use that. Obviously, that algorithm is not going to function as well as an algorithm which uses fasting, PP, and an HbA1c, but it'll do better than not using a clinical decision support. Similarly, hypertension is easy because there are blood pressure measurement instruments everywhere, right? So you need to have a systolic and you need to have a diastolic, and that's about it. So this is what we then ended up doing. We started working on the basic principles of management of diabetes. What do we need to do when somebody comes with diabetes? Modify lifestyle, add medication. If they're on no medication, we'll say that the first line is metformin. If the person is If the person is already on oral agents, then you can actually increase those oral agents. How much you increase it will be based on the algorithm, whether you need one incremental dose or two incremental doses. If they are on multiple oral agents and they're not getting control, we need to add insulin. So this was the whole sequence flow, which I as a physician would use in my OPD. And then again, we decided, how would you do escalation, right? So we would start with generic medications at the lowest level, either metformin or a sulfonylurea, because those are available as per the Indian public health standards in government health facilities. Then we keep on building up and adding more medicines if control is not being achieved with the existing medication, right? So just another example, this time we modified the algorithm. I'd shown you the grid for fasting and HbA1c. This time we said there's no HbA1c likely to be possible. This is a lower level facility. So let's see what we can do with fasting and PP, right? So we had multiple ranges of fasting glucose on the top, less than 130, 130 to 160, 160 to 200, more than 200. You can decide what you want. You can create your own numbers. And similarly, a postprandial less than 180, between 180 and 250, between 250 and 300, more than 300. So again, these are numbers. You will decide what you would rather. And the arms varied from reinforcing lifestyle, adding one incremental dose. So 500 milligrams of metformin, 2 milligrams of glimepiride, 15 milligrams of pioglitazone, or 2 incremental doses. But if you see here, if you're at more than 200 fasting and more than 300 pp, we've actually said bring insulin into the system. This is now the algorithm for fasting glucose alone. And again, you've got this, and we've got to modify because we don't know. So we've said if it's under 130, you're fine. If it's above 130, you will require incremental doses. And if it's based on PP, again, the same thing. You can keep on increasing depending on postprandial values. We went on to do the same thing, and I'm not going to take you through each one of them, but to give you an idea, right? So we said we will make a basic entity of a hemoglobin A1C. So if somebody's hemoglobin A1C is less than 7% and we have fasting and PP, based on this grid, we will give you incremental advice of increasing or decreasing the dose. If it's between 7 and 8%, and these are the fasting and PP values, this is what we're going to do. If it's more than 8%, and these are the fasting and PP values, this is what you're going to do. So the basic principle remains very much the same. You create categories, you make a table, you make grids, and this is a generic advisory. 1 incremental dose, 2 incremental dose, add insulin, right? And 1 dose is predefined at the back end. It could be either 500 milligrams of metformin, it could be X milligrams of another agent, it could be Y milligrams of a third agent, but it's very clearly defined. The doctor doesn't really have to worry so much. It's going to come up in the front end as soon as the calculation is done, and that calculation happens immediately. We similarly developed insulin algorithms that we said if the fasting glucose is high despite multiple doses of oral agents, add a single dose of basal insulin. If despite adding basal insulin, we are finding that the post-meal increments are high, it's time to consider adding pre-mixed insulin. Again, I won't go into details, but this was again worked up with how it's being done through basal insulin. How do we up titrate it based on self-monitoring? And similarly, very clear advisory on how you would like to incrementally change values if you're on pre-mixed insulin. These are the blood tests that you need to do. These are the numbers which you need to look at. If morning values are this, or postprandial values are this, or pre-dinner values are like that, this is what the advisory is. So this is where your clinical set, and as physicians who I assume we're all physicians on this call, as in doctor physicians, this is critical for us. This is where your skills of trying to management patients will come in. You have to do your own set. This is what we felt would work. I've already shown you evidence that these decision supports help in management. They improve control, right? Over a period of time, you may have new medicines, you may have new insulins, you may have new blood pressure lowering medication that can change. So this is not a static entity. You will review evidence, you will change your grids, you will change the scenarios, you will come up with new rules. Now, obviously, the other approach would be if you can bring in AI, then you don't have to create the rules. The AI will learn on its own through iterative thinking and come up with these advisories. So I think this is really the basic thing I'd like to convey to you. So we're currently doing this in Punjab. In fact, we're virtually finishing this project. This is just to show you an hierarchy of institutions, and we're covering everything from frontline workers, giving them a mobile phone which is capturing the critical information. This information is available in the prime sub-centers in the health center for screening and confirmatory diagnosis, and then at PHCs and above to take decisions about treatment. This is the actual way it's being done. So that's the National NCD portal. We've linked our clinical decision support software through a rule engine, and it draws information from the electronic case record form. And as you can see from this particular side, the patient's parameters go to the clinical decision support system, and the personalized management plan comes back into the electronic case record. Everything to the right is not visible. It's at the back end. All that is visible to the doctor or the nurse is the case record form with the information, and back comes the advisory. And this is an example of, this is real stuff. So this is as it's happening in those facilities in Punjab. This will be the information on one side, the recommendation on one side, which will also say preferred option is do this, second best option is do this. What else are we advising you to do? Come back after a period of time, after 1 month, 2 months, whatever it is. Now, unfortunately, please remember, what you and I want to advise on a medical basis may not be applicable sometimes in government health facilities, because patients may be expected to come back earlier because they're not given medicines for longer. So I may say, you're fine, you can come back in 3 months, but they have to come back earlier because of the fact that medicines are supplied for only a shorter period of time. Was this actually taken up by the doctors? I'm really happy to tell you that if you look at the bottom half, that if somebody received a printout in those facilities, that meant that the patient had been seen by the physician with support of the clinical decision support software, because otherwise you could not print a prescription. And you can see that between 70 and 90% of the times, the patient was being seen by the physician with assistance of this clinical decision software. So we've now sort of developed this in extreme, and I'm about to sort of finish it off in the next couple of minutes. So the big items are, we can generate a personalized clinical management plan. We can identify people with high risk. We've actually also strengthened the referral mechanism. So we are saying that if at a primary health center, there are only 2 medicines available for blood pressure, the person is getting full doses of those 2 medicines, the blood pressure is still not under control, that's a trigger. We trigger a referral to the next higher level of healthcare, and the same information is available through the government's NCD portal to the community health center and the medical specialist sitting out there. We also give follow-up prompts. We also give advisories about secondary CVD management. And more importantly, we also consider comorbidities. So supposing somebody in the electronic case record form has an abnormal kidney function test, automatically the prompt will not give you advice to take all those medicines which are contraindicated in a person with kidney failure. Similarly, if you're hypertensive and you have chronic obstructive pulmonary disease, it'll automatically say, don't give this person beta blockers because the COPD might get worse, right? So we're fortunate that this system is now enabled, and is at the flick of a switch, it can be made operational in the Government of India CPHC NCD system. This is again to show you all the work that we've done, but even more exciting for us is that in the new operational guidelines for the National Program for Prevention and Control of Non-Communicable Diseases, the government has decided, based on the evidence we've provided, that the clinical decision support system should be integrated into the patient pathway, which is because of it being a robust system, which is causing immense benefit to patient management. And this is very much part. States can opt for this, and there are mechanisms by which that this can be made operational. I'm going to stop here just by saying that it's been a 12-year journey for us to understand clinical decision support. I'm sure there are many people who are doing this work, but we are fortunate that we had a large team of people, both physicians, non-physicians, administrators, bureaucrats, health system specialists, and IT specialists who've helped us do this. Clearly, this is something which is useful, whether you use rule-based algorithms, whether you use AI, but a support to the physician. Please understand, it's a support to the physician in managing their patients using objectivized management prompts, which derive their objectivity because they are developed from evidence-based guidelines. Thank you so much for listening, and I'll be very happy to take any questions if there are. Thank you once again.
Thank you very much, sir. There's one question in the chat, sir. What could be the medical-legal implications of following or not following the management prompts for treatment using the CDS?
Right. So there are no medical-legal significance at all. The decision, so it's like, forget about the CDSS prompt for a minute. Just imagine that you're a person sitting in the OPD and you have a textbook of medicine right next to you, and you're consulting that textbook of medicine, and based on that textbook of medicine, you're coming up with a decision, and you're saying, oh, Harrison says that if a person is living with high blood pressure, which is classifiable as mild hypertension, either give a calcium channel blocker or give an angiotensin receptor blocker at starting dose. You're reading that and you're giving the treatment. Eventually, the responsibility is the physician's. The physician is taking ownership. You are absolutely entitled to accept or reject or modify the prompt. It is a support. It's a clinical decision support system, and it is derived from available evidence-based guidelines from professional associations and based on scenarios which are created from real-life practice.
Professor Suksarin sir had commented that it was an excellent and most educative session.
Thank you, sir.
We have one more question. How does one get involved in creation of the CDSS with Dr. Tannen's team?
So I can type out my email address out here. Perhaps that's the simplest. Can I do that?
Sure.
Will I? Yeah. Isme kar do? Can I? I'll just do it. Meeting group chat mein kar deta hu. I think that'll be the simplest, because otherwise, and we can have that conversation. Right. So that's just my name, Nikhil_Tandon at hotmail.com.
We have one more question. Care coordination between the healthcare providers in and out referral for continuum of care is part of CDSS.
So CDSS, again, before anybody goes in, CDSS is not replacing the health system. CDSS is one more tool to assist the health system. So it's like in an OPD, I'm sitting and I'm part of an hierarchical system. I'm a doctor in a primary health center. The government has a multi-tiered healthcare system. There are community health centers above the primary health center where sometimes there are medical specialists, or there's a district hospital above me. Now, we have to be sure that we align the patient's needs with the human resource skills, drug availability, and diagnostics available at that level of care. Now, if you feel that at that primary level of primary health center level, there's a person with diabetes and 80% of them would be manageable at the primary health center level. Let me be very, very honest with you. Is a mild diabetes, marginally elevated fasting PP, the doctor there is giving maybe 500 milligrams of metformin twice a day, sugars are well controlled, nothing is to be done. But then you will have a patient who's coming to that PHC who's been escalated doses, despite maximum doses of the two medicines which are available in the pharmacy of that PHC, the sugars are not controlled. It's time to refer. Or you're finding that this person this time came in and he has a diabetic foot and they require to be seen by a surgical specialist who is not available. So these are referral triggers, referral prompts. The advantage of the government system is that the same electronic health record is visible to the entire hierarchy within that system, right? So if I'm working in a particular district, that person is visible, a record is visible to, let's say, a surgical specialist in the district hospital whom I may have referred the patient to. They can concurrently see it. So when that patient goes, theoretically, they have a prior information and this process can be facilitated. So these are all facilitatory mechanisms. Primary health centers, and community health centers and district hospitals have always been there in our country. The question is, persons with complex disease may still be languishing at primary health care, and patients with straightforward disease may be go to district hospital because, hamare ghar ke paas. So the idea for referrals was up referral to the level of care which is required to control and manage their disease, and down referral to the lowest level where stable management can be done without. So, once a person at the top has said these 3 medicines are required, blood pressure is well controlled, bring them down to whatever level, because now onwards it'll just be follow-up and dispensing.
CDSS, which is rule-based, requires data collection. Isn't there a problem with poor data input?
Oh, absolutely. Garbage into the data collection, garbage will come out of the CDSS. Absolutely correct. So what we did was, when the whole process was being developed, we were very much part of development of the electronic health record for the government of India. We actually need very little information. Number one, it's not that you need 500 variables. You need current medication and you need a blood sugar. You need current medication and you need a blood pressure. And if there's any additional information, and it's a very, very simple form, the entire information is captured on one form. At the end of the form, you can trigger the CDSS. Right? Now, physical examination, which can only be done by a physician, is not there, and therefore it doesn't contribute to the CDSS that much. But short answer to your question is, you're absolutely correct. If the information which you're inputting, it's like saying, I want to add 4 plus 4, so that I'm going to get an 8 in the calculator, but I'm putting 2 plus 2. Obviously, you're not going to get 8 because this inputted wrong. So inputting correct data has to be very much part of this.
CDSS for differential diagnosis at a primary care center level, what is available?
So at the moment, I don't think anything is available, but you must understand that IMCI was developed, IMNCI was developed for pediatricians, very good system, which was working on a book. Similarly, you have in different countries of the world, you have emergency modules which work on books. All of that can be converted really into algorithmic care. Now, if you don't have software, I showed you those tables. Management of diabetes can be done by those tables, right? Except that is going to give you a broad advisory. The moment you can convert that into a CDSS, it'll take up options and give you more specific advisories with names, doses, and follow-up durations. If you don't have that, you have those tables, which are systolic pressure, diastolic pressure. There were 12 fields or 12 squares. Look at that and go ahead and do it.
What about the lifestyle management? Can that advice be included in CDSS along with treatment?
So lifestyle management is a trigger for all non-communicable diseases, and therefore it's part. So the workflow usually is you go through a non-physician healthcare provider, go to the physician, and then come back. If there is a specific lifestyle advisory which is required, it can be built in to the electronic health record pop-up box, which can then be used by the non-physician healthcare provider to give advice by physical activity, for diet, for whatever. Very much doable, depends on how dexterous your electronic health record is.
One another problem with CDSS seems to be that doctors needs to spend time in front of the computer than looking at the patient, similar to the EHR system in the USA. Any comments on that?
Yeah, so I think that's a valid comment. But what we've done is, and I, that video was not going to work. But really what happens is that the way we've done it, the doctor doesn't have to do any inputting of data. The patient is going to the non-physician healthcare provider, who could be a data entry operator, who could be a nurse. And this is actually how the health system has been envisaged by the government of India's national program. So by the time the patient comes in, the doctor has that information on the screen. They can continue to talk to the patient as they would normally do. And there's only one screen with the advisory sitting in front of it. So your point is valid, but it's very, very different from what you described and rightly described about electronic health records in the West, in developed countries. This is pre-digested, triaged information coming as a single screen in front of the physician, who has to really enter nothing. He has to say yes, no. Obviously, if he wants to change the advisory, he'll have to change it because it's like writing a prescription.
What are the factors that will affect implementation and management of CDSS?
So that is a very important question. A CDSS, so we built in our CDSS into a government system. Now, if the government system is operational, which has to be done by the government, all that is needed to make the CDSS functional, because it's already integrated into the government system, is for that state to say, I want to try the CDSS in all my healthcare facilities in this district, 5 health facilities in this district, 1 facility in this district, and the IT backbone of the government system just has to flick a switch. No additional software, no additional hardware. The only thing will be a half-an-hour training that is required. So that is it. Obviously, if the doctors are not keen to do it, if there's no electricity there, if the internet provision is not there, it will not work. I mean, that's, so please remember, you will require, you can't expect, sophisticated technology to work in the absence of some degree of back-end support.
There are 2 more questions. How often the CDSS algorithms shall be revised with changing trends and protocols of treatment?
Yeah. So, I think, again, that's a very important question from a clinician's perspective. What normally happens is that a lot, let's say for diabetes, right? So the American Diabetes Association will bring out clinical practice guidelines annually, right? We should not go into papers. We should go into professional society guidelines. So the Research Society for Diabetes of India comes out every 2 or 3 years so we will need to upgrade based on that evidence at the same frequency. So if the Cardiology Society of India or the American Heart Association or the European Heart Society for Cardiology changes hypertension guidelines, I think we should change our algorithms accordingly.
Last question, is it possible to minimize manual error by those with difficulty in understanding software at grassroots level for CDSS usage, given the number of patients in PHC or CHC to be taken care of?
Right. So again, I think these are very, very important questions. From an implementation perspective, we've actually done it. So I can speak with something. So you remember, this is not every patient. This is at the moment functioning for people with non-communicable disease at the moment, starting with just diabetes, hypertension. Okay. So it doesn't have to be used. PHCs will be busy, but the requirement for using this is going to be restricted to 10% of those patients. Not 90%. 90% of PHC will still be maternal child health, will be infectious diseases, will be other stuff. So it is not the entire workload of a PHC. I think we need to really understand that.
More question. Won't the CDSS exclude the doctor from the healthcare system? Won't people without medical knowledge use it and cause themselves more harm than?
So the CDSS access is not available to non-physicians, right? So the CDSS access is physicians. You have to have privileged access to the health system to be even. So if I am a data entry operator, I don't have a privileged access to the CDSS. Only if I have the privileged access as a physician will the CDSS prompt become visible to me. Otherwise, it will not become visible. So it's not available for population-based visibility.
I would like to thank Professor Nikhil Tandon sir for his informative session. It was very informative, and we can also see the response from the audience who had been very interactive. And I know that there will be a lot of questions still more, but due to paucity of time, we will have to go for the next session. And if needed, they can mail to the NAMS email or to sir's email, which he had kindly put in the chat. And we will make sure that you get back the responses. We request sir to kindly give the responses to the questions, compile the questions and give it to sir. Thank you, sir.
Thank you. Thank you so much, everybody.
I would like to invite the next speaker of today's session, Dr. Chetan Arora, sir, from the Department of Computer Science and Engineering, IIT Delhi. Dr. Chetan Arora, sir, is a professor in the Department of Computer Science and Engineering, IIT Delhi, and he is a joint faculty with Yardley School of Artificial Intelligence and ANSK School of Information Technology. His research interest includes trustworthy artificial intelligence, making modern computer vision systems using machine learning techniques trustworthy, cancer detection, computer-aided detection models for detecting cancer, mobility, developing computer vision techniques for driving assistance and autonomous driving systems in the Indian context, egocentric vision, computer vision applications arising out of body-worn egocentric cameras, problems with social impact, developing camera-based wearable device. And Dr. Arora has more than 25 projects with national and international agencies and a large number of publications in national and international journals. It's an honor and privilege to have you here with us, sir. Over to you, sir.
Thank you. Thanks for the introduction. Let me just allow me to share my screen. So I hope my screen is visible. Is the screen visible?
Yes, sir.
Oops. All right. So thank you again. Thanks for inviting me. And I think I will, in some sense, be coming from the opposite direction of what Professor Tandon was speaking about. So I'm a computer scientist by my training, and we are working on some of the healthcare problems. So perhaps Dr. Serene felt it fit to invite me to talk about some of the works that we are doing in the application of AI for the healthcare. I think there is a lot of I have interacted with the doctors, so there's a lot of gap between the way we as engineers look at the things and the way the doctors are trying to look at the thing. In this talk, I will try to be, let's say, as less technical as possible. But please, I apologize in advance if this talk looks a little more technical than you might have expected or anticipated. So there's a lot of discussion about AI and a lot of discussion
Excuse
about
me, sir.
Yes.
Sir, your camera is off.
My camera is off.
Now it's on, sir. Now it is visible, sir.
Okay, so if I do this, now it is off?
Yeah, it's off now, sir.
Okay, so it looks like that when I move the zoom out of my screen, then it becomes off. Okay, so I'll let it sit on the bottom right. Okay, so I hope it's visible now, the camera?
Yes, sir.
Yeah, okay. So there's a lot of discussion about use of AI for the healthcare, especially within the radiology, where we are talking about the images, etc. So a lot of it is correct, but lots of sometimes we have to really distinguish between what's hype and what is really true. So what I wish in this discussion is really to take you through what is the typical, let's say, process on when we are trying to develop an AI-based technique for some healthcare problem, in this case, the gallbladder cancer detection. What are the kind of things that come in the way, how we develop those tools, so that hopefully through this talk, we will also understand, and maybe if you would like to apply the AI techniques for your own problem, you will understand what kind of things you may be able to use. So because unlike what you may gather, let us say, from the social media or from the news, that something just happens magically out of the box, things like that, and you get this one CNN model and apply it on the data and just magically things start to happen. That's not really true in the practical scenario. There's a lot of effort, there's years of effort that goes behind it to really make some of these models, some of these tools work on a specific problem. And so I will take this, I will use this slide more as a use case in the sense that if when we try to use it for the gallbladder cancer detection, what are the things that we applied, what were the problems that we considered, and how we try to solve them. And hopefully many of these ideas you can actually take it to the other cancer detection problems or the other problems of your interest. Okay, so as I mentioned, I'm a computer science engineer by training. So when I'm not doing healthcare, so the kind of things that we are working on, which was also discussed in the introduction, is the mobility. For example, when we are talking about the autonomous car and we have the camera looking at the road and we have to understand the scene so that the car can drive itself. Or we are trying to look at, so there are these modern AI techniques, let us say for the face detection. How can we mount the attacks on this system? So how can we prevent the attacks on the system? So these are the kind of problems that we are working with. We also work on, so these are the problems which I would like to call the computer vision kind of problem, where the input is typically an image. But we also work on more generic AI kind of a problem where we try to make these techniques more trustworthy. So it may happen that, for example, let's take the example of the cancer, that AI may say that with confidence 0.99, it's a cancer, whereas it is not. Or it may say with a very low confidence that it's a cancer, whereas it's a very obvious kind of a mass or the tumor which is present and should be detected with a high confidence. So both ways things can go wrong, and which actually erodes, let's say, the confidence of the AI model for the users, in this case, the doctors. So we also develop techniques which can make these techniques more trustworthy. So these are the kind of things that we do in the healthcare, not healthcare. So in the context of the healthcare, the kind of things that we're currently working on are, one, the gallbladder cancer detection, something which I will be talking in detail in today's talk. But some other things which I may not be able to discuss more is, for example, we do the breast cancer detection from the mammograms. So this is work that we are doing with AIIMS daily. Similarly, with the neurosurgery department, we are also working on developing simulators for training the surgeons for the neurosurgical skills, and then also developing tools to automatically evaluate them for their skills. In the context of the data management, so I was just hearing the last talk by Professor Tandon, that so there's a lot of data that gets captured. So there is some data entry operator or some other ANM or somebody who's just taking down the data from the patient and then actually putting it on the computer so that the doctor can see. But many times one will feel that in this case, the entering process becomes the bottleneck. The established process or the conventional process are the paper-based, and we want them to be digitized. And then this link becomes a weak link in the whole chain. So we also work on developing tools which can ease up in this process. So for example, we have this, let us say this MCP card, the mother and child protection, and we have this vaccine return. So is it possible that rather than actually making an entry on the computer, we just make an entry on the regular way on the booklets, etc. But in the end, we just take a picture, and through this picture, we develop tools so that all this data can be digitized automatically, but just by looking at this picture. So those are also the things that we do. Coming to the, let's say the main topic which I wish to discuss today is our work on the gallbladder cancer detection. So I know that I'm in the front of the doctors, and as an engineer, I'm not sure whether this slide should be more informative, but at least this will make sure that we are on the same page in the terms that what I know about gallbladder cancer and or how I look about the gallbladder cancer. So it's a worldwide disease, about 84,000 deaths every year. 5-year survival rate is very bleak, 5%, and the mean survival after detection is typically 6 months. The reason, or one of the reasons for this bleak figure, is because the metastasis happens very quickly because the gallbladder sits just adjacent to the liver, and oftentimes it progresses silently in the sense that the patient does not have any symptoms, and that's why it gets detected very late, and that also contributes to the bleak survival rate for the gallbladder cancer. Now, so what is our motivation to get into developing AI tools is that there have been evidence that if one can detect the gallbladder cancer early, or if we provide resection, the mean survival rate can increase to 44% also. On the other hand, what we know is that the non-expert radiologist often performs very poorly on the ultrasound images, which are typically the modality in which we try to diagnose. In fact, in some of our experiments, what we have seen is that even the expert radiologist with 7 years of experience, for example, working in the gallbladder cancer, has a sensitivity of only about 70%. So what we envisage is that if we could have this AI-based automatic detection, it can potentially work as a second reader, which can improve the accuracy of the detection as well as can be used for the triage purpose. So with this motivation, we started collaborating with the doctors from PGI Chandigarh. So this is so we have a collaborator there, Dr. Pankaj Gupta, and so we started working on this, and so we'll see. I mean, what we could develop in the last few years. So now, why ultrasound sonography for the GBC? So it's what we understand is that it's the most common imaging modality that one uses for the abdominal ailments. And very often, this is also the sole diagnostic imaging that one performs on the patient. It's highly accessible and low cost compared to, of course, CT and MRI available in the primary healthcare centers also. And for the GBC detection, it's often a very excellent candidate. On the other hand, the gallbladder cancer is a very India-specific disease. So we have we are the country with the highest burden of the GBC, and because of that, there is often little to no work that has been done for the application of AI-based techniques for the GBC detection technique. So in fact, when we started this work about 3 years earlier, we were perhaps the only one who were working on that. And slowly, with some of the resources that we made available in the public domain, we see a few more groups that have joined our efforts and now developing or working on the GBC detection now. So what are the challenges with the USG modalities? Now, these challenges I would like to describe as an engineer, as a developer for the AI tools, not necessarily the challenges with respect to the doctors. So what we see from the automated tool perspective is that the image is typically of a very low image quality. And when I say low image quality, I'm comparing it with the CT and the MRIs and the other such modalities, which are typically much clearer in terms of seeing where the masses are or where the organs are and things like that. In the case of ultrasound, we often see a lot of noise, and we also have the very significant artifacts, which because of the shadows, the shadows from the ultrasound. And because of both this reason, noise as well as the shadow, we often see the textures which are spurious in these images. And these are the textures which start creating problem in the case of the automated tools for the detection, because the models, the automated models that we develop start to overfit or start to really rely upon these spurious textures rather than the real ultrasound or looking at the features in that region to detect the gallbladder cancer. The biggest challenge that we see in the use of the USG modality for the automated tools is the handheld sensor. So most of the time when we're talking about, let's say, the CT or the X-ray, the person is made to stand or sit in a particular way, and the image that one gets is a very standardized kind of version. So if I'm looking, let's say, for the CT scan for the gallbladder, I will always see the gallbladder in a particular way. On the other hand, when we are talking about the ultrasound, these are the images which have been taken by a doctor. So depending upon how much pressure one puts in, or which angle one looks at it, and which position exactly on the abdomen the sensor has been placed, the image that gets for the gallbladder, the same region, for example, from the same patient, the image could be very different. From the tool perspective, it adds to a very high degree of variability. So you can say that I'm looking at, for example, I mean, if I give the example from the natural images, I'm trying to detect, let's say, a scooter versus bike, and now I'm saying that the viewpoint could be invariant. I could be looking it from the top, I could be looking from the side, or from the bottom, or from somewhere. Now you can imagine that if I introduce this variability in terms of the viewpoint, the problem becomes more difficult really to learn that this view, I mean, if I look at this view and the picture looks like this is a scooter or a motorcycle. So the same thing happens for the ultrasound imaging for the AI tool also. That because of this handheld nature adds into the viewpoint differences and then makes the problem more difficult to learn. Coupled with it, we have the anatomy of the gallbladder itself, which is irregular, which means that even if I were to really take the picture from the same angle, etc., the anatomy will say that the picture will come out very different. From patient to patient also, the structure is not very well defined, and I can look at all kinds of shapes then that one can see the gallbladder in. Just to illustrate my point, I have added a few images also on the slide, which will show that even if I talk about, let us say, all malignant or all benign cases, I may have a very high intra-class variance, whereas I may have a very low inter-class variability, which means that in terms of the pixels, in terms of the image, there will be very little difference between malignant and benign, but there can be a lot of difference, in the visual features between the two benign cases itself. So that also adds to the complexity in terms of the learning, in terms of how one develops the AI tool for it. Now, something which is true for all, typically all medical imaging problem is the lack of annotated data sets. So I cannot say that one should have a very large number of cancer patients in the hospital. We do not wish that. But say that if we have 500 patient data, that's also a large number, let us say, from the cancer perspective. So the 500 patient data becomes very small compared to what we are really used to working in the natural image. So when we work on, let's say, the road scenario, the mobility scenario, we're talking about millions of images which one can train with. Whereas when we're talking about the medical imaging problem, we are talking about the images of the order of 500,000, 1,200, this order. So with all those variations that I said above, high intra-class variance, low intra-class variance, viewpoint invariances, lots of noise, shadows, etc. And then you say that the images are also less. For that, it becomes an extremely challenging problem to train any AI model for this kind of a task. Now, understanding these challenges and the motivation, the key research question that we posed when we started working on the gallbladder cancer is, can we really make this work? So can we really develop the tool which can actually overcome all these artifacts such as noise, shadows, etc., or can overcome this variability in the viewpoints and yet give me the high detection accuracy? Now, once high detection accuracy has been achieved, this is not the only thing that one desires in a medical imaging problem. So if I tell you that, okay, this is the gallbladder image and this is malignant in terms of the cancer, and this is another gallbladder image which is benign, the next logical question that the doctor would like to ask is, on what basis this decision has been made? Which means that I do not wish only the high detection accuracy, I also want an interpretability. The model should be able to explain a decision that this malignancy has been said on the basis of this ABC reasons, or this benign this sample has been declared benign because of some such reason. So these reasons has to be interpretable to the doctor, which means that the doctor should be able to understand the two reasons and then accordingly take the management decision for the management of the gallbladder cancer. The other question that we have to answer in the key research question is, can we learn from the limited supervised data? So I cannot expect that I will be given a large amount of data. I have to still work with the scarce label data. And then how do I design the reliable models under this scenario? And will this AI model, whatever I have developed, will work across the subgroups that one can observe? So these were all the questions that we asked for us. And as I will show in the next few slides, we tried to solve them each one by one. So the first requirement for development of any model in the AI is the availability of this data set. So this is where we started with also. So we got access of about 1,200 samples from 212 patients, 218 patients from the PGI Chandigarh. So this was a single center data that we got. About 990 of them. Yeah, so about 990 of them were not malignant, they were benign or normal. And about 265 of them, 265 image sample out of them were malignant. All these malignants were proven through the biopsy. So this is the data that we started working with, and what we will show that the tools that have been developed have been tested and validated on this, as well as some of the other data sets that I will be describing soon. Okay, so the first thing, as I mentioned, the key research question was, can I design an accurate GBC detector, so the gallbladder cancer detector, through the ultrasound images of the gallbladder? So what we came up with, and this is again important for not only for the gallbladder cancer, but for the cancer detection problem in general, is that it's very hard to classify
Excuse me, sir. Sir. We are trying to contact sir again. I think there is some internet problem.
Hello.
Hello.
Yeah. So I received a call that I was not audible, perhaps. So
Yes,
until
yes.
what point you could hear me, and I can maybe start from there.
So 2 minutes back, sir. Like,
So I became not audible 2 minutes back. That's what you're saying?
sir. Yes, sir.
Okay. So broadly, at what slide?
So if you show the slide, I'll be able to see.
So this one is okay.
This was also visible, sir.
Okay.
This was also visible. Next slide, sir. Yes, I think over here it got disconnected.
Okay. All right. So I'll just restart from here. So understanding, let us say from the gallbladder cancer perspective, that what are the challenges with respect to the USG imaging. So the key research question that we asked for ourselves was, how do we detect accurately the gallbladder cancer in these scenarios? Something which becomes very important in the healthcare scenario specifically is not only the accuracy, but also the interpretability. So one is usually not satisfied just by saying that for this particular image, this cancer is malignant, or this cancer is benign, or this gallbladder is normal. But we also wish from an AI tool that we should be able to interpret its decision. So the AI model should be able to explain its decision. And whatever explanation the AI model gives, the doctor should be able to understand it also. So we have to really align it with the language that the doctor would understand. So the other challenge, or the other key research question that we have to handle, is that can all this be done? The interpretability as well as high accuracy detection can be done only from the scarce label data. Okay, so this is a constraint that we have especially in the case of the healthcare, that we have to work with it. And then whatever models that we develop, we should be able to trust its prediction, which means that if I say with a very high confidence, the chances of that prediction becoming accurate should be more than if I say something with the low confidence. So this confidence should be related to the trust that one can pose on the model. And then the other answer that we have to see is that, is this AI model can work across different patient subgroups. So it's not that for one particular kind of patient, this model is highly accurate. For the other kind of patient, this model is highly inaccurate. So this is the kind of thing that we cannot allow. So these are the key research questions that we have tried to handle. And in the next few slides, I will try to explain how we have done that. So extremely important for any development of any AI tool is the availability of the data set. So this is the first thing that we started with. So we got access to about 1,255 samples from the PGI Chandigarh, and these were taken from about 218 patients. Out of it, 265 were the malignant, and 990 were either benign or the normal. All the malignant image sample were all proven through the biopsy. So this is a data set that we have captured at PGI Chandigarh, and this data set is also now available publicly, and I have given the link to the data set in the slides at the bottom of the slide. So now coming to our work on designing of the accurate GBC detection model. So what we developed so coming to the accurate detection of the GBC, so something which looks very obvious on the face of it, but has not been done in many of the scenarios, is that it's very difficult for an AI model to really learn the useful features if I give a lot of distractions in the image. So for example, in the case of the GBC, if I give this whole image that one sees here, the gallbladder occupies a very small area. And with the availability of, let's say, only 1,000 images, and then asking an AI model to learn from this 1,000 sample, what are really the features for the GBC, becomes a very difficult task. So one easy thing through which I can make this problem easier to learn is by looking at only the region of interest. So in the case of the gallbladder cancer, it becomes obvious that the region of interest is the gallbladder itself. Okay, so anything in my image which does not belong to the gallbladder should not be the basis of detecting or predicting this image, this sample, as GBC positive or GBC negative. So what we do in the first stage is that we try to detect this region of interest. Typically, so these region of interest will be some region of gallbladder that have been identified or that have been shortlisted for the closer scrutiny. So this is what we call the ROA selection. It broadly locates the gallbladder within the image. Then in the second case, we try to classify this gallbladder region. So here, I'm not trying to go into the detail of the classifier. So we have built this classifier, which is what we call the multi-scale second order pooling. So this is considering the specific features that we are interested in the gallbladder cancer. So these are the texture features that we want. So the second order pooling really helps me capture those correlations that we are interested in looking at. And multi-scale allows me to look at this image at the multiple scales. So I want to look at a very higher granularity and at a very smaller granularity. And all this together, when I make, we create an architecture which combines all of this together and then makes a prediction. So the innovation that we made in this particular work were twofold, let's say. So one was a use of the ROI that we wish to do. And the second was the designing of the specific architecture, which I'm talking about, this MS-SOP, which is multi-scale second order pooling based classifier. Ultimately, at the end of the day, it's still a CNN. I hope that many of you have heard about this CNN, this convolutional neural network. So it's a CNN, but it's a CNN of a specific kind that we designed specifically for the gallbladder cancer or for looking at the ultrasound images. And on the basis of it, it classifies whether an image is benign or malignant. Okay, so one more innovation that we did in this particular context is, as I mentioned, that in the ultrasound images, unlike the CT or unlike the natural images, there's a lot of noise that one has, and there's a lot of shadow that one observes, which is not there in any other imaging modality. And what happens is that even if I develop this multi-scale SOP kind of a classifier, it still starts to overfit on these noise patterns or on these shadow patterns, rather than really looking at the features of interest, which often is the presence of the stone and the loss of edge between the gallbladder and the liver and those kind of things. So the model is not able to learn those kind of features. So something that we did in this particular architecture, in the particular model, was getting inspiration from the visual acuity that one observes in the human beings also. So what we know from the human vision development is that when we have the children, they have a very blurred vision. Okay, which allows them, which becomes very important also in the development, the vision development process, because it allows to broaden, it allows the brain to really develop a broad set of features to recognize object. So for example, on the left, if I show you this particular image, When we do not have very sharp feature, it becomes very important that I look at the larger region to really detect whether it's a tree in this case or not. Whereas as the human vision develop, so we start to look at more fine-grained texture also. For example, in this case, the leaf, which means that I can use only the leaves also to say that, okay, this is the picture of a tree, for example. But because the features have already been ingrained in the brain about the larger shape feature, so brain now starts to make use of both the low resolution features as well as the high resolution feature to really make sense of the object. Now, this is a very important concept which we try to include in the neural network also, that if I somehow reduce the visual acuity of my image, then the model will be forced to really look at the broader shape features, etc., to really make the decision. So this is what we also do. It's just that for implementing in the neural network, we have to do some other tricks. So what we do is that we introduce the Gaussian blurring to simulate this visual acuity. So what we have developed for the training of the model is we have developed this training curriculum that we call. So in the beginning, when we are training this DN model, we give only the images which are highly blurred. So for example, with this sigma is equal to 16. So this is a standard deviation for the Gaussian blurring. So it's a highly blurred image, and one is not able to look at the broad texture. Now the broad texture, of course, is gone for the gallbladder, but it's also gone for the noise also. So which means that the network starts to rely upon the broad shape kind of a feature for the gallbladder, that is the shape okay or not, are the stones present or not, those kind of things to really make the decision. And as the training progresses, we keep on decreasing this blurring to the extent that the last few training epochs happen with no blurring at all. But because the model has been trained with a particular curriculum, it starts to rely upon both the shape feature, which are a little global feature, I should say, as well as also the high resolution features. So with this kind of a visual acuity based curriculum, we are able to handle this texture bias. Now, when I'm saying texture bias, this is a texture because of the noise. I mean, there is some real texture of the cancer also, which we want to pick up, but this is a texture, or this is a spurious texture, which is appearing because of the noise. So what I'm showing you here is that we did this particular experiment to really say that have we been able to overcome the bias due to this noise texture. So what we did is that we took this, let's say the regular image, and we added a synthetic texture, so which is visible in the second image. So we take this and we add this synthetic texture, and then we train the model that if the left image is the benign or the normal sample, then even after this addition of the texture in some spurious places, the classification should not change. And with this, we train a particular model. And then what you see in the right side image is that if I do not use this kind of a curriculum while adding the synthetic texture, at the test time when I try to do that, the GBCNet starts to predict this as a malignant, whereas if I have actually trained it in this particular manner, that there are spurious texture which can appear at random places and one should not get biased with that, the model is actually able to learn that these are spurious and not necessarily important for the decision whether it should be benign or malignant. And on the fourth image, one can observe that it indeed predicts it as benign even when this spurious texture is present. So the key result that we wish to bring in is this. So the first, okay, let's focus on the last two rows first. So the GBCNet is the design that I mentioned about, the multi-scale SOP kind of architecture along with the ROI things. And the GBCNet plus VA is when we add the curriculum according to the visual acuity. So the blur images and then the non-blurred images. And you could observe that we get about an accuracy of 91% for the 3-class classification problem when we have to say malignant, benign, and normal. And for the 2-class accuracy, when we have to just say malignant and non-malignant, we get an accuracy of about 95.9%. In terms of the specificity and the sensitivity, we all do a pretty reasonable job with 95 and 97.6% sensitivity. Now, these results become important when we start contrasting it with the radiologists. So we had 2 doctors in the PGIs, so where we could actually test with them also. And we tested with those radiologists and their accuracy in the contrast. So when we are talking about the 3-class accuracy, whereas our model gives the accuracy of 91%, the accuracy of the radiologists were merely 70 and 68. And in terms of sensitivity, when you're talking about, so the sensitivity was merely 70.7 and 73. So The GBCNet, the model that we talked about, was able to give a much higher sensitivity compared to radiologists alone. Now, I would not like to overclaim the results also here, in the sense that these have been validated on a very small data set captured from a particular center. At this moment, we are actually in the process of doing a multi-center study. So where we are trying to collaborate, we are actually reaching out to multiple hospitals, trying to take some of the data from them and see how the GBCNet performs on this kind of a new data, because we can understand that from the center to center, there's a difference in the machine, there's a difference in the capture modality, different radiologists. So there are chances that the accuracy may not be this high on the different centers, but this is something that we are actively working at. In terms of the qualitative analysis, so one can see the results here. So the top image, for example, is the malignant image, and the regular AI model. So these Resonant 50 and VGG16 and Inception V3 are the conventional cancer detection model which are available for on the internet, publicly available. They all give the incorrect prediction in this case, whereas the GBC correctly does this. One should also know these color patterns that we have seen. So the red means that these are the regions in the image which a model is relying upon to make that decision. So one can see that in the case of, for example, Resonant or VGG or Inception, most of the time this red region is not exactly even on the gallbladder itself. Okay, so either it's a very large region or it's a small region which is outside the gallbladder. So which means that the network has not even been able to let us say learn what are the important regions to really look at. And because we were going in the ROI selection and then classification way, one, we are able to detect what is the right region to look at for detecting malignancy. And then we are often able to predict it correctly also, whether it should be classified as malignant or non-malignant. Okay, so this was something about what we did for the accurate detection of the gallbladder cancer. The other thing which I discussed that one should be aware about is the interpretability of these decisions also. Now, so there is one thing to say that I am 95% accurate or I'm 90% accurate, but I must be also able to say that this sample has been classified positive because of this reason, or this sample has been classified negative because of this reason. So this is what we took up next. The interpretable decision, interpretable GBC detection. So we had to change our architecture to really help that because when we were talking about the previous architecture, it was, let's say, 2000 dimensional large feature vector. And because of which the decisions were being made. And even if I say that, okay, this decision is malignant, I'm not able to really pinpoint what exactly contributed to that. So for the purpose of the interpretable GBC detection, we created a different model which works with the global and local attention. So just something like the previous one where I was saying that we took a ROI and then classified it. So in the same way, but with a slightly different architecture, we have this global attention branch which focuses on the small region in the image. Then we crop that region based upon this global attention, and then give this cropped region into the local attention, and then we do that. The biggest change that happens is in the transformer branch. So what we're trying to do now is that instead of creating, let's say, this arbitrary feature vector of 2048 or this kind of a number, we talk about the feature map, which are two-dimensional. Okay, so we are talking about now the H by W, which is the height and width. So this is a 2D feature map, and then multiple such feature map. So what we can do, how we can interpret or how we can visualize this is, let's say I say that this is a USG image, and in this case, the wall thickening is present. Now, what we interpret is that one of the feature in this layers will correspond to the wall thickening, and what is the location in this will correspond to at what point I saw the wall thickening. So this is something that we call the visual words now. Okay, so just like when we have the document, we are saying that this document is of class A because there are certain words present in it. In the same manner, in the context of the images, I'm saying that this image is being classified malignant because there are these features which are present in it. And because this is an image, I need to know the location of it also. That's why these features or these words are not just like single one-dimensional. These are also two-dimensional images by themselves. So this is how we try to formulate the problem of the interpretable GBC detection. So these are the things that one observe. So once we have trained this particular model, now we start relating our features with what a radiologist will say. So what I'll first see is that, let us say there is a feature number 1321, which is active whenever I am saying that this sample is malignant. So what we do is that we take these samples to the doctor and say, what is the common thing that you see whenever this 1321 feature is active? And then we ask the doctor, and then we get this description, what you see. And this description is as per the GB-RADS lexicon. So for example, whenever this 1321 feature occurs, the doctor is saying that there's a loss of interface between GBC and liver. So now what we know is that the 1321 feature captures this aspect in the sample. Similarly, whenever the feature number 1955, 1807, these features are active, we see extramural invasion. So now we connect these features with this particular GB-RADS lexicon that we have now. Now, once we have done this exercise, now we have this feature map to the lexicon mapping, which means that whenever the new sample is presented to this particular model, then it can actually look at its activation, which features have been found. And based upon this feature activation, it actually starts explaining that I'm saying that this sample is malignant because of this GB-RADS reason. So these are some of the samples that I can show you. So this is, for example, the original image on the top left that one sees. This is the ROI that we have shortlisted to analyze further. And then what we see is that the feature number 1321 activates for detecting this as malignant. And this feature number 1321 has been connected to loss of interface between liver and the GB. And again, the red region will say at which point the model thinks that this loss of interface has happened. Similarly, in this particular case, this feature number 638 is also active, which means that the model would like to say this as malignant because it is also seeing mural thickening in this particular sample. And again, the red regions will indicate at which point it has seen the mural thickening. In the bottom image, again, the model predicts this as a malignant one. The second image shows what region has been focused upon to really make this prediction. And the third and fourth image will say at what point those features have been identified, and the feature description is written on top. So for example, in the second row, we see that there are two reasons for the malignancy that has been cited, which is mural stratification and mural changes with echogenic foci. So now with this model, not only we are saying that this is malignant or benign, but the model is also able to explain why it said so. And this becomes extremely important, as you can see in the problem of the cancer detection. Now, given the amount of time, so I think I will skip this two things that I thought about. We'll talk about the unlabeled videos, etc. And I'll come directly to the subgroup analysis that we have done. So this is the recent work that we did, and it was recently accepted in the Lancet Regional Health also, where we did the subgroup analysis. So we put our model to test on the prospective study. So this was our DL model. So this is the same DL model that I was talking about, the MS-SOP model, which we chose for the prospective diagnostic study. And here we compared our diagnostic performance with the two expert radiologists, just like we had done for the original work. And we were able to show, or we performed this analysis for the polyps and the mural thickening, for the contracted gallbladder cancer and neck lesions, etc. So for this prospective study, we chose 565 patients. Out of them, 233 patients were put into the train, and 273 were put for the held out test set, and 59 were used for the validation of the model. So this is how we did the data acquisition. So we had the radiologists with us, which had 1 to 8 years experience. And these readings, the diagnosis were done independently by the two radiologists, one with the 2 years experience and one with the 8-year experience, exclusively in the abdominal ultrasound. And both of these radiologists, though, were aware that the patient had GBC disease, but they were blinded to what the findings are. Okay, so that's how we compared with them. And these are the output of the model. So on the left column, we see that what is the ground truth, what is the true picture. And on the right-hand side, one can see what is predicted by the particular model. So there are 4 images that I'm showing here on the slide for 4 different types of cases. So one is with the mass, the other is with the mass with thickening. And we are also saying thickening and the polyp also. So these are the output of this particular model, which have been tested prospectively on this particular data set. Now, in terms of the AUC of the DNN, the model, the deep neural network versus the radiologist. So we have shown this chart for the 1- specificity versus the sensitivity, and one can observe that the AUC of the CNN is much higher, or has a much higher value compared to both the radiologists. So this was evident in the previous case also, when I was claiming that the accuracy comes at about 72% versus the 95%. This is on the prospective study for the DNN versus the radiologist. And this is the performance in various subgroups. So the overall, or in the case when the stones are present, the mass is present, the thickening, or the polyps, or the contracted GVC. And in almost all the cases, what we have observed is either the DNN performs at par with the radiologist, or at times much better in terms of the sensitivity across various subgroups. So this is what we are doing currently in terms of what the future works are. So we are developing two kinds of services. So one is the web application that we are developing, so that this is a web-based service. So you can actually upload your image and see what is the prediction of the particular model. We are also developing an IoT device. So it will be a 4-inch by 4-inch small mini computer, which you can actually take it to your hospital and feed it the images, and then see the device, see the decisions that has been made for your assistant. So it can be used as a second reader in that particular case. So we have developed both the devices, both the things, web application as well as the IoT. And we are right now looking for also the partners, so that we can actually test it at multiple locations. We are also working on the video-based detection, so something that I could not really describe because of the paucity of the time. So the ultrasound is also an interesting modality in the sense that not only the images, but I have the videos also. So we have done some work where we can actually analyze the videos and actually make use of this many frames or many images that are available to me to actually develop more robust classifier. So this is something that we are doing currently also. We are aware of the fact that whatever model that we have developed are still the single center. So which means that when we go to the different hospital, there is likely to be some kind of a domain shift. This is a technical word which we talk about when the distribution of the images changes. So in the PGI, for example, we expect that the image distribution will be of one kind. And when we go to the other hospital, this distribution may change, which may lead to the failure. So we have to develop the generalized model. But for that, we have to get new data from different hospitals. So we are actively reaching out to different hospitals to get access to this data and train our model on that. We are also working on the CT-based detection now, specifically for the target therapy perspective. So for example, if we could detect HER2-neu from the CT images, so that the appropriate targeted therapy could be made available to the patient. And just to end my talk, so this is the web app. This is the web demo that we have developed, and you can write to me at some point, and we'll be happy to open that for you. Give you access on this web app where you can upload your images and do that. Now, one thing which we have done in this particular case is because we also want that we get access to the crowdsourced data. So we allow you to upload your images, but we also ask what is your prediction on it. Okay, so that this model is more like a second reader. So we get a record of your prediction, what you think this gallbladder image does, what the ground truth says, if you have the access to the biopsy of that, and then we can actually give you the prediction of our model. So we have about 4 different models now. And you can actually select which model output you want, or if you want all the model, we can show the output from all the models. So this is the state where we are in, and I'll be happy to take any questions now. Thank you.
Thank you very much, sir. It was a interesting and informative session. We have a question in the chat. Can we use publicly available data for AI building, and are these patentable?
No, so it depends upon which. Our work in this case, the data set that we have is you can use it publicly. Of course, you cannot use it for the commercial use. For any academic or research purposes, you can use it freely. So you can, so if you go to that website, it will ask for you to fill up a form that you are using it for the research purposes. You email it to us and we release the data set to you. That's how it goes. And all the models that we have developed, we are releasing it publicly also. For that, there is no form, so you can just download it from the GitHub and start using it for your own purpose. The data set is on site in the form.
Thank you, sir. Till other questions comes, any legal challenges, legal issues that can happen with this?
See, we are just like the previous talk also, we are placing it as a second reader, in the sense that just like you're referring to a book or something, then you're referring to the AI model also, what does it think? But still the decision of what you wish to do with that, whether you want to completely ignore that or we should look at it more carefully, that particular sample, is still up to the doctor. So it's more for your aid rather than a decision. So it's a decision support system.
Regarding the privacy and confidentiality of the data, do we get the consent from the patients, etc.?
Yeah. So this is what we have done at the PGI. So we do have the consent. We have this the ethics committee approval also before we started collecting this data. So all of these processes have been followed. And on top of that, we do not, in the AI, we do not work with the DICOM images, which actually have a little more problem in terms of the confidentiality. We work with the JPEG images where we take only the pixel data. So which means that this connection of which patient to which image is broken at that level. So that also helps us maintain the confidentiality or the privacy.
Okay, sir. There's one more question in the chat. If we develop supervised machine learning model for prediction of any disease, how much data we should have?
Okay, so in this case, I mean, that's a very common question that I get. So what we say is that more the merrier. So as much as data you can give, so it will help the training process. But at the end of the day, what we say it, I see it more as a constraint, that I have got a certain number of image, and then we say that, okay, this is the problem that has to be solved with that particular data. But definitely, as we get more data or as we get more varied data, the problem becomes easier to deal with.
If we have float type supervised, very limited data, is there any way to increase the accuracy?
I did not understand what is float type, but if we have a lot of supervised data, then yes, the accuracy is likely to improve.
So Vikas, would you like to explain what did you mean by float type supervised?
I thought that maybe it's a typo, so it wanted to say a lot of supervised and it became float type.
No questions, sir. So what is the difference between machine learning and statistical models?
Okay, so typically the statistical model are a little more math oriented, in the sense that we would like to give the mathematical guarantees over whatever decisions or whatever predictions we are making. In the case of ML, we are a little more aligned towards the prediction, that the prediction should be correct, and we are not talking that much about the mathematical guarantees. But having said that, we use many statistical modeling tool in the ML and vice versa. Yeah, so it's more about, let's say, the broad objective or broad desirable from a particular tool.
So there's a comment from Professor Sivsarin, sir, that it was an excellent talk.
Thank you. Thank you.
Dr. Garima has asked another question. Kindly repeat how we can access these AI models for our clinical practice.
I'm sorry, can you repeat the question, please?
Can you repeat how we can access these AI models for our clinical practice?
See, what we have done right now is, as I said, there are models which have been made publicly available. So you can definitely download it and start using it. To help, I mean, or let's say to lower the bar of the usage, we are developing, as I said, two different versions. So one is the web-based. So you can just go on the browser and upload your image. That's one case. If that is problematic because the image is going outside your hospital, then the other model is that what we are developing, this 50,000 rupees mini computer. So you can just take this mini computer sort of thing from us and use it locally in your hospital.
Question, is it online? Then which type of server is deployed?
Oh, so at IIT, we have in HPC what we call high performance computing. So we have deployed it there. Yeah, but from your perspective, you just see a browser where you can upload image and you see the result. I mean, you don't have to bother about the backend. I mean, but this is required because we expect that there may be many queries at the same time. So we require a little more stronger server. When you are the only one who are going to access, then this 50,000 rupees thing also suffices. So that's what we have done. So we have put it on the 50,000 rupees machine also, which you can just buy it, but it will be able to do one request at a time, sort of, not many at the same time.
They have also asked what type of infra has been deployed.
What kind of infra has been deployed, as in for at your end, or what we have?
So what you have, I think.
Okay, so typically IIT has a lot of infrastructure for deploying or developing all these models, but as a user, you do not need that. So what you can do is, as I mentioned, that we have either you use as a web service, which we plan to put it more on a trial basis, because again, I don't think that IIT still would have a capability to do this commercial scale service. So we'll definitely expect that at some point of time, some private company or the government takes over from us and put it for the wider use. But until that happens, what we are expecting is that, as I said, so this is NVIDIA Jetson, which you can actually buy off the shelf from any, I mean, off the shelf. I mean, just go Amazon and buy that. And then you can put our software on that thing, and it should be up and running for your end. I mean, so we are still not at the commercial stage, so that I would not like to say that, okay, I will keep on supplying to all of you. But definitely, if you wish to collaborate with us in terms of, so because there is still a lot of domain adaptation, domain generalization that has to happen. So we have to test it at many hospitals. So if you wish to collaborate with us in that you like that, okay, this data also comes in and we are able to improve the model, then definitely I would be happy to hear from you. And in that case, we'll be happy to give you that machine. You test it on it, but then we get back the data from you in return.
It answers the next question also, that can we buy the computer from you?
So is it, so I see Ram Shankar, is it online? What type of, so the model is online. You can definitely download it and run it. And it should work with a reasonable memory server. So for example, if you have a machine with 64 GB or 128 GB of RAM, it should be able to work. But if you do not want that, you can make it work on the small device also, the Jetson kind of devices also, which will come much cheaper that way. But I mean, so we have not tested on all kinds of stuff, but with slow speed, it should still be able to work on your laptop, but it may be slow.
Okay, so Dr. Sukumar has asked, can we get your email address?
Yeah, so I can type in, or otherwise that's my name itself. So Chetan @iitd.ac.in, but I can type in somewhere.
The chat,
yeah, I can put it in the chat.
Thank you very much, sir. It was a very wonderful session. It was very interactive also. So due to the paucity of time, I think the participants can then mail their questions to either to the NAMS email ID or to sir. So with this, I think we can end the session, and I would like to now invite Professor Ajay Kumar Sood, sir, the Deputy Secretary, National Academy of Medical Sciences, to deliver the vote of thanks.
Thank you so much, Dr. Preeti. It is indeed my great pleasure to propose a vote of thanks on behalf of the National Academy of Medical Sciences. We are extremely grateful to the distinguished speakers for this evening, Professor Chetan Arora from IIT Delhi, as well as Professor Nikhil Kandan from All India Institute of Medical Sciences. I'm sure that the complex topic of artificial intelligence and use in clinical practice, the way you have explained, I think most of our PG students, at least they have been sort of encouraged and stimulated to go for these technologies of the future. And both the example which you have given, as well as the Professor Tandon, like non-communicable disease, diabetes, hypertension, and now the cancer, I think these are the areas which are going to be big problem in the future. So thank you so much for your valuable time and contribution. And on behalf of the student, again, I am grateful to you. And we look forward for your support in future also. I would also like to place on record the support and guidance which you have got from the Director AIIMS, Dr. M. Srinivas sir, and President NAMS, Professor S.K. Sareen, for guiding the whole program. And with their support, we have been able to sort of encourage the medical college and AIIMS, and we have registered nearly 1,000 PG students. I will also like to thank the students who have been with us this evening, although the number was nearly 250 or 300. We're expecting in the coming days it will increase. This is your own program, and you can always give us your suggestion, your feedback, what type of topics you want to cover, and also encourage your fellow students to join us. So this is a very unique opportunity. We are going to have direct interaction with the senior most expert in the country. So please do give your feedback. And for your information, we have already circulated with the brochure, which gives you the main themes in the next few months, which we are going to cover. The next theme, which we are going to cover on 6th of October, is again very interesting, where we are going to discuss about patient protocols, patient safety protocols, hospital-acquired infections, and how we can practically manage the waste and what care we should take in the ward. So if you have any question related to these topics, you can always email to us, and we'll try to sort of inform these to our speakers so that these can be covered during the session. So thank you so much for being with us. And we hope that in the future also you will be making this session more interactive. I will also like to thank Dr. Preeti, a faculty member from All India Medical Sciences. She has been attached to the program from the very beginning for organizing this particular session and moderating this. Thank you so much for your support to National Academy of Medical Sciences. And then I would like to place on record the support which we have been getting from our own staff, our secretary, NAMS, Professor Umesh Kapil, who has been the team leader for us in organizing the session. Our IT unit, we have Mr. Ravi and Mr. Anil, who have been helping us in the background and also ensuring that this is properly telecast or broadcast on the Zoom as well as on the YouTube. So once again, I would like to thank all of us, all of you who have been with us this evening, made this session very interesting and interactive for us. So wish you all the best and see you in the next session, which is on next first Friday of October. That happens to be on 6th of October. So please send your question and queries related to the topic, which is on patient treatment protocol, safety protocol, as well as hospital. So thank you so much. Over to you, Dr.
Thank you, sir. So declare today's academic session closed. Thank you, one and all.